Everyone. So, am I visible? Am I audible? So, let's start today's session. Just give me a quick confirmation in the chat box that I am visible and I am audible. Hi, Carpal Tunnel. Hello. कैसे हो यार? How is everybody? How are you doing? Just give me a quick confirmation. I'm still waiting for a confirmation in the chat box because I can't see. Uh, I can't see. Okay, just give me a quick confirmation in the chat box that I'm audible and I'm visible. Good evening, Reshma. How are you? Hello. So we'll start in 2 minutes. Okay. So in today's class, we'll try to finish it quickly. Okay, because exams are coming very near and I don't want to take a very long class. There is no point in taking a long class now. It is self-study which is most important right now. So the purpose of this class is to, brush up a little radiology of yours, so that, am I visible? Just give me a quick confirmation. Am I visible? Okay, so thank you for that confirmation. I am yet to see myself talking. It's good that you are able to see me, but I can't see myself in the YouTube live. So just let me figure that out so that there is no lag from my end. Okay, so just give me 1 more minute. Yeah, so we are good to go. Okay, so in today's class, I've covered it in multiple sessions. So first we'll start with the anatomy. Okay, I want to cover some questions of anatomy, some important topics related to radiological anatomy because that is asked in the exam. ठीक है, one or the other किसी ना किसी एग्जाम में पूछा गया है, so it is important for us. ठीक है, how hi Manoj, hi Samanna, hello everyone. So just give me a quick confirmation in the chat box. Which exams are you guys preparing for? Are you still in your professional exams? You're preparing for your professional exams? NEET PG, November INI-CT or FMG? Which exams are you preparing for? Just give me a quick confirmation in the chat box. ठीक है बैसला, इंग्लिश में बात करेंगे, डोंट वरी. NEET PG, good. ठीक है, so let's start with the first question. Let's not waste our time. Our target is to finish the class at 9:30 so that you can have dinner and get over with this class. I don't want to take a very long class. ठीक है, great. Thank you for that confirmation. So first tell me, let's quickly identify A, B, C, D, E, F, G, H, everything in this image. So I won't wait for the answers here because it is supposed to be a 10 kadam very rapid revision. So I'll straight away tell the answers here. So A is pointing towards my right lung, right? B is my manubrium sterni. Tell me C whether C is aorta or C is pulmonary trunk. Tell me C is aorta or pulmonary trunk. I'll label the rest meanwhile. Okay, this F is very easy to identify. This is my descending thoracic aorta. Okay, what is G? G is my vertebral body. H is my spinal canal. And also tell me in the comment section, I am labeling a structure by this red arrow. What is this structure? Tell me in the comment section the red arrow structure as well. So what is C? C, tell me what is C? C is pulmonary trunk or aorta? So it is definitely not RV. So remember at T4, T5 level, I'm talking about which level am I talking about? This is T4, T5 level, which is very, very important from both your anatomy point of view and your radiology point of view. Okay? So T4, T5 level per anterior vessel is pulmonary trunk. रिमेंबर T4 T5 पर पल्मनरी आर्टरी आगे होती है, एओर्टा असेंडिंग एओर्टा पीछे होती है उसके. सो D इज माय असेंडिंग एओर्टा. ठीक है, दिस इज अ वेरी वेरी इंपॉर्टेंट पॉइंट. ठीक है, डोंट मिस्टेक दिस फॉर aorta. Anterior structure at T4 T5 vessel is my pulmonary artery. ठीक है, I hope you got this concept correct. This will be asked one day or the other in the exam. ठीक है, रेड कलर से क्या स्ट्रक्चर मैंने मार्क किया है, टेल मी इन द कमेंट सेक्शन, रेड कलर से क्या स्ट्रक्चर मार्क किया है. चलो इतने, आई लेबल अनदर स्ट्रक्चर, दिस एयर फिल स्ट्रक्चर, दिस विल बी माय ट्रेकिया. ठीक है, ये मैं स्ट्रक्चर दोबारा, एक और वेसल है जो राइट साइड में है, कौन सी होगी ये, SVC. तो रेड कलर से मैंने कौन सा स्ट्रक्चर मार्क कर रखा है, दिस इज माय ईसोफेगस. यस, दिस इज माय ईसोफेगस. गुड. ठीक है, अब आपको कैसे चलेगा पता कि ये T4 T5 लेवल है. सो ये इमेज याद रख लो. ठीक है, ये इमेज याद रख लो, सिंपल यही आंसर है इसका. ठीक है, T4 T5 लेवल पे हमें पता है कि असेंडिंग एओर्टा खत्म होती है, डिसेंडिंग एओर्टा स्टार्ट होती है, पल्मोनरी ट्रंक डिवाइड हो रही होती है, ट्रेकिया डिवाइड हो रहा होता है, तो ये वही लेवल है. ठीक है, एंटीरियर वेसल विल बी पल्मोनरी आर्टरी, पोस्टीरियर टू दैट विल बी असेंडिंग एओर्टा. वेरी इंपॉर्टेंट. चलो नेक्स्ट. नेक्स्ट हमारा डिसऑर्डर बताओ एक. ठीक है, रिलेटेड टू एनाटमी ओनली, वेरिएंट एनाटमी है. बेरियम swallow I have given barium swallow. Patient has dysphagia. I am giving the history. Patient has dysphagia. There is a posterior smooth indentation. Mark my words. Posterior smooth indentation on the esophagus. ठीक है, बेरियम swallow है तो esophagus देख रहे हैं, पीछे से स्मूथ इंडेंटेशन है. NCT दे रखा है, क्या है आंसर, टेल मी. यस, द आंसर इज अर्सा. अर्सा अभी पूछा गया है, दिस नवंबर, दिस मे INICT. वेरी वेरी इंपॉर्टेंट अनोमली, आई हैव टॉट इट इन द क्लास रिपीटेड टाइम्स. वेरी इंपॉर्टेंट अनोमली, एबरेंट राइट सबक्लेवियन आर्टरी. ठीक है, कैसे आइडेंटिफाई करेंगे इसको, जो ईसोफेगस है, ये वाला जो रेड एरो मार्क कर रखा है, ये वाला, ये ईसोफेगस है हमारा. दिस इज माय ईसोफेगस. एंड ये एरोहेड से जो मार्क कर रखी है, दिस वेसल इज माय अर्सा. इट गोज पोस्टीरियर टू द ईसोफेगस. तो याद रखो, एक और आपको बज़वर्ड बता रहा हूं, अपर थोरैसिक लेवल पे अगर सीटी स्कैन दे रखा होगा तो वर्टिब्रा के आगे कोई वेसल नॉर्मली नहीं होती है. वर्टिब्रा के आगे अपर थोरैसिक में कोई वेसल नहीं होती है. लोअर थोरैसिक में होती है, डिसेंडिंग एओर्टा पास में होती है और आगे भी नहीं होती. अपर थोरैसिक में वर्टिब्रा के आगे अगर कोई आपको वेसल जाती हुई दिख रही है तो वो अर्सा है, तो वो अर्सा है. ठीक है, एबरेंट राइट सबक्लेवियन आर्टरी. ठीक है, कभी कभी अब एग्जामिनर कैन आस्क यू दिस VRT इमेज ऑल्सो. दिस इज अ वॉल्यूम रेंडर टेक्निक, 3D इमेज बना के भी दे सकता है. तो ये वाली कौन सी वेसल हुई हमारी, ये हुई हमारी ब्रेकियोकेफलिक ट्रंक. देन द नेक्स्ट वेसल कौन सी निकली हमारी, ये वाली हमारी निकलेगी लेफ्ट सबक्लेवियन आर्टरी. एंड फिर ये बाद में जो एरो हेड से मार्क्ड हो रखी है, ये वाली वेसल, दिस इज माय अर्सा. ठीक है, ओरिजिनेटिंग बियॉन्ड द लेफ्ट सबक्लेवियन आर्टरी. ठीक है, इसका ओरिजिन बियॉन्ड द लेफ्ट सबक्लेवियन आर्टरी है एंड गोज टू द राइट साइड, गोज टू द राइट साइड. ठीक है, दैट इज हाउ यू आइडेंटिफाई अर्सा. वेरी वेरी इंपॉर्टेंट. ठीक है, चलो नेक्स्ट. अब क्योंकि हम वी आर टॉकिंग अबाउट एनॉमलीज ऑफ द आर्च, एक बार पूछा गया है अर्सा तो हमें सब पढ़ना पड़ेगा. फटाफट टेल मी, आई हैव टॉट इट इन माय क्लास. पहली कौन सी एनॉमली है, वेरी कॉमन एनॉमली दैट वी सी इन practice, that is why I have included. This is bovine arch. bovine arch कैसे पहचानेंगे bovine arch को, bovine arch क्या होता है कि जो लेफ्ट कॉमन कैरोटिड है उसका और ब्रेकियोकेफेलिक ट्रंक का कॉमन ओरिजिन है. अब आपको कैसे पता कि ये ब्रेकियोकेफेलिक ट्रंक है, देखो ब्रेकियोकेफेलिक ट्रंक, व्हाट डज इट गिव राइज टू, ब्रेकियोकेफेलिक ट्रंक गिव राइज टू राइट कॉमन कैरोटिड एंड राइट सबक्लेवियन आर्टरी, है ना. एंड लेफ्ट कॉमन कैरोटिड का अलग से ओरिजिन होता था, है ना. बट इफ हियर यू आर सीइंग देयर इज कॉमन ओरिजिन ऑफ ब्रेकियोकेफेलिक ट्रंक एंड लेफ्ट कॉमन कैरोटिड आर्टरी, दिस इज नोन एज माय बोवाइन आर्च. कॉमन ओरिजिन ऑफ लेफ्ट कॉमन कैरोटिड आर्टरी, कॉमन ओरिजिन ऑफ लेफ्ट कॉमन करेटेड आर्टरी एंड ब्रेकियोकेफलिक ट्रंक। ठीक है, आपको जो लेफ्ट सबक्लेवियन है, देखो जो लेफ्ट सबक्लेवियन है उसका ओरिजिन सेपरेटली दिख रहा है। लेफ्ट सबक्लेवियन इज सेपरेट बट लेफ्ट कॉमन करेटेड एंड ब्रेकियोकेफलिक इज कॉमन। दिस इज बोवाइन आर्च वेरी कॉमन एनोमली। ठीक है, ये गलत नहीं करना है, ये आपको कोई पढ़ाएगा नहीं बट वेरी कॉमन है, आ सकता है। नाउ अब एक वेसल आपको ऐसी मिलेगी, जिसमें ईसोफेगस और ट्रेकिया एनगल्फ होगा अपर थोरैक्स में, like an inverted V. So this will be my double aortic arch. ठीक है, एग्जाम में ये ऊपर वाला डायग्राम नहीं मिलेगा, मैंने समझाने के लिए बता रखा है आपको। इन्वर्टेड वी होगा डबल एओर्टिक आर्च, इन्वर्टेड वी। वेरास अगर सीधा वी होगा, वी शेप्ड, तो मतलब क्या है, इट इज अ राइट एओर्टिक आर्च। दिस इज अ राइट एओर्टिक आर्च। ठीक है, सुतापा समांतर इज आस्किंग व्हाट्स डायग्नोसिस फ्रॉम बोवाइन आर्च, मतलब समझ नहीं आया। बोवाइन आर्च का मतलब है कॉमन ओरिजिन एंड आर्च, it is a type of arch which gives a common origin to the left common carotid and the brachiocephalic trunk. This is my brachiocephalic trunk, this is my left common carotid. तो ये आर्च होती है बोवाइन आर्च। ठीक है, बोवाइन एनिमल से मिलती है, दैट इज व्हाई इट इज कॉल्ड बोवाइन आर्च। वेरी कॉमन अनोमली, कैन बी आस्क्ड। नाउ अगेन आई हैव given you a section of the chest. Quickly tell me what each of these structures is. So first tell me this A and B. Tell me A and B. Tell me A and B. I'll label the rest meanwhile. So ये कौन सी वेसल होगी हमारी? अच्छा, आप बोलोगे सर अच्छा कौन सी मोडालिटी है ये? MRI है, मैंने बता ही दिया, MRI है, सिंपल है। क्यों? क्योंकि हमारी बोन्स जो हैं वो डार्क हैं। दिस इज एन MRI, करेक्ट। कोई बंदा मुझे ये बता सकता है कि कौन सा सेक्शन है, T1 वेटेड है कि T2 वेटेड है? कोई बच्चा बता सकता है T1 वेटेड है कि T2 वेटेड है? चॉकलेट क्वेश्चन है। ठीक है, चलो आई लेबल द रेस्ट ऑफ द वेसल्स एंड T2 बोल रहे हैं लोग। ओके ओके, अच्छा T1 T2 में कैसे डिफरेंशिएट करते हैं हम? वी लुक एट द फ्लूइड। नाउ अपर थोरैक्स में फ्लूइड कहाँ दिखेगा? कहाँ दिखेगा? स्पाइनल कैनाल में दिखेगा। अपर थोरैक्स में हमारे पास वर्टिब्रा है, स्पाइनल कैनाल में फ्लूइड दिखेगा। एंड देखो आप, जो भी स्पाइनल कॉर्ड के चारों तरफ एरिया है दैट इज ब्लैक, मतलब हमारा CSF फ्लूइड यहाँ पर ब्लैक है। दिस इज एक्चुअली अ T1 वेटेड MR इमेज। कोई पूछेगा नहीं आपसे। दिस वाज अ वेरी वेरी इंपॉर्टेंट कंसेप्ट दैट आई वांटेड टू टेल यू कि अपर थोरैक्स में T1 एंड T2 को डिफरेंशिएट करने के लिए यू लुक एट द CSF इन द स्पाइनल कैनाल। ठीक है, बस एक कंसेप्ट याद रखना। चलो फटाफट बताओ व्हाट इज A एंड व्हाट इज B। व्हाट इज ए एंड व्हाट इज बी? सो ए कौन सा है? चलो इतने, ये व्हाइट एरो में क्या है हमारा? दिस व्हाइट एरो विल बी माय डिसेंडिंग thoracic aorta। ठीक है, एक ये वाला मैं मार्क कर देता हूँ, ये क्या स्ट्रक्चर है? ये ईसोफेगस है, कोलैप्स पड़ा है जो, एक छोटू सा यहाँ पे डॉट पड़ा है, ये एक वेसल है, वेरी इंपॉर्टेंट, मे बी आस्क्ड, रेयरली मे बी आस्क्ड। दिस इज एन एजाइगस वेन। ए क्या है? अच्छा, सेक्शन क्या है? हम बात कर रहे हैं उस सेक्शन पे जहां पे डिवीजन हो रहा है एक वेन का, एक वेसल का, एक ये जा रही है, एक यहां जा रही है। अब बताओ ए क्या है, बी क्या है? ए है मेरा असेंडिंग एओर्टा एंड बी है मेरा मेन पल्मोनरी ट्रंक। नो, A is not SVC, नो, A is not SVC। ओके, आई स्पीक इन इंग्लिश ऑल्सो। ठीक है, सो ए इतना बड़ा सा वेसल है। वेसल क्यों है? क्योंकि फ्लोवॉइड आ रहा है इसमें, तो इट विल बी वेसल, इट विल नॉट बी एनीथिंग एल्स, है ना? सो इट विल बी अ वेसल ओनली। बी कौन सा स्ट्रक्चर है? ये वाला है मेरा मेन, दिस इज माय मेन पल्मोनरी ट्रंक, दिस इज माय एओर्टा। ठीक है, बाकी स्ट्रक्चर्स आई हैव लेबल्ड। दिस इज डिसेंडिंग thoracic aorta, this is azygous vein, this is esophagus, this is esophagus। ठीक है, पीहू इज आस्किंग अ वेरी गुड क्वेश्चन, व्हाट इज फ्लो वॉइड एंड व्हाट डज इट हैव टू डू विद वेसल? सो एमआर में रिमेंबर T1 एंड T2 वेटेड इमेजेस में वेसल्स अपीयर डार्क। आप देख रहे हो कि आई हैव लेबल्ड डिसेंडिंग thoracic aorta, pulmonary artery, but sir you are looking at them and seeing that they are black, whereas in the previous CTs that I showed, the vessel was very bright. Okay, so modality is different. CT में we give IV contrast, iodine appears bright on CT, that is why you see bright color within the vessels, whereas in MR, high flowing blood like in aorta, like in pulmonary artery, like in superior vena cava, so high flowing blood, it will appear dark. This is known as flow void। ठीक है, चलो now we'll move on to the next question। ठीक है, this is anatomical question, this is an anatomy question, but if a question is asked on this, it will be coming from radiology, you will be given an MRI image, you will not be given an anatomical image। ठीक है, so I am talking about very very important structure in the brain, that is circle of Willis। ठीक है, एंड सर्कल ऑफ विलिस पे अगर कोई क्वेश्चन आएगा तो इट विल बी एन एमआर इमेज। सो लेट्स जस्ट लेबल द arteries forming the circle of Willis, correct? So first of all, tell me this vessel which is going and turning like this vessel which is going and turning like this, what is this vessel? I am labeling it with this arrow। Okay, tell me A, so tell me A। now I am labeling another vessel which is this B, then I am labeling C, then I am labeling D and E। Tell me quickly in the comment section what are the arteries that I have labeled, A, B, C, D, E। Tell me in the comment section what have I labeled। So A is my internal carotid artery। ठीक है, what is B? B is anterior cerebral artery। what is D? D is posterior cerebral artery। and what is E? E is posterior communicating artery। C क्या है? Good, C you have rightly said, C is my middle cerebral artery। C is my middle cerebral artery। So one of the arteries I have not yet labeled, which forms the circle of Willis. So which artery have I not labeled? So this is an artery which communicates the two anterior cerebral artery. It's not visualized here, so I have not labeled initially, but this is my anterior communicating artery, ACOM। ठीक है, ठीक है, गुड, एंटीरियर कम्युनिकेटिंग आर्टरी। ठीक है, सो लेबलिंग ऑफ सर्कल ऑफ विलिस ऑन एमआर इज वेरी वेरी इंपॉर्टेंट। ठीक है, नाउ सेकंड क्वेश्चन विच कैन कम विद रिगार्ड्स टू MR imaging is, for example, a stroke patient can be given, and you can be given an infarct of the right hemisphere, and in that case you will not see the right middle cerebral artery. ठीक है, वहां पे कोई thrombus जमा होगा, so there will be infarct on the ipsilateral side. Okay, now let's, after arterial anatomy, quickly I'll tell you the venous anatomy. Won't ask you questions because it's easy, right? So superior sagittal sinus is labeled here. Okay, the topmost venous sinus of the brain. Then we have the inferior sagittal sinus. This is my inferior sagittal sinus. Then the straight sinus connects the inferior sagittal sinus with the superior sinus. This is my straight sinus. And straight sinus also drains the deep cerebral veins. So the deep venous system, or I can label it as deep cerebral veins. Okay, now these two are my transverse sinus, which are well appreciated on a coronal image. And finally, this S-shaped sinus, this is a sigmoid sinus, which continues inferiorly as internal jugular veins. Okay, easy to understand. You guys already know this. Okay, now let's come to the next image. Come to the next image. So you guys will tell me what is 1, 2, 3, 4, 5, 6, 7. I'll wait for 1, 2, 3, 4, 5, 6, 7. I'll start labeling from 7. You tell me 1, 2, 3, 4. Okay. So what is 7? 7 is again a air containing structure, but it has a thick wall. It has a thick wall. So this air containing structure having a thick wall, this is esophagus. Whereas another air containing structure which is bigger and has a very thin wall, this is trachea. ठीक है. Fifth, what is fifth? Can someone label fifth क्या है? Fifth vessel है, most right vessel है, सबसे right side में है हमारी. This is SVC. ठीक है, तो बाकी आर्टरीज पहचाननी अब आसान हो गई. फोर्थ होगी हमारी ब्रेकियोकेफलिक ट्रंक. थर्ड विल बी अवर लेफ्ट कॉमन कैरोटिड आर्टरी. वन विल बी अवर लेफ्ट सबक्लेवियन आर्टरी. And 2 is again a vein which is anterior most vein in the anterior mediastinum. Second is left brachiocephalic vein. क्या क्या सही हुआ सबका? सब लोग डिलीट कर रहे हैं. एवरीबडी इज डिलीटिंग नाउ. No, I'm not labeling. Pulmonary veins will not be seen at this level. Anuj, pulmonary veins will not be seen at this level. Pulmonary veins drain where? They drain in the left atrium. So you will see heart. You'll have to see heart to label any vein as a pulmonary vein, right? So this is never a pulmonary vein. Anterior most vein in the anterior mediastinum is a brachiocephalic vein. Potential question. Okay, and now tell me, I've already told you which is this vessel that I have labeled. Chalo, let's quickly move on to the musculoskeletal anatomy now. So let me tell me guys, what is this ligament? What is this ligament? This is easy, anterior cruciate ligament. This one will be my posterior cruciate ligament. Okay, I have labeled annotated image also. What will be these? These will be menisci. And you can see a tear. This horizontal white line is a tear in the menisci. This is how meniscal tear appears. And what will be these two ligaments here? This will and this will. Which one is medial? Which one is lateral? How do you identify medial and lateral? You look at the fibula. Fibula is on the lateral aspect of the leg, So the ligament attaching to the fibula will be the lateral collateral ligament. ठीक है, and similarly the opposite will be the medial collateral ligament, right? Now you guys have not answered in the comment section which is this vessel. You have not answered. This is nothing but ursa again, aberrant right subclavian artery. ठीक है, I told you any vessel in the upper thorax going anterior to the vertebra, this will be ursa. This will be ursa, and to confirm it, you can also see that it is indenting the trachea. This is here. This is my, sorry, the esophagus. This is my esophagus. It is going posterior to the esophagus. So again, ursa, fitting into ursa, aberrant right subclavian artery. ठीक है. Now last anatomy question, last anatomy slide. इसके बाद we'll move on to pathologies. Yes, good Anuj. ठीक है. So these are shoulder girdle muscles. In the first image, I have labeled them. ठीक है, because I understand you might not have seen them, but since you know shoulder is an important part in anatomy, there are high chances you can get a labeling question based on shoulder muscles in your radiology also. So we know that above the spine of scapula, above the spine of scapula, the muscle that is there, this is the supraspinatus. Above the spine of scapula, this will be supraspinatus, and naturally inferior to it, the bulkier muscle will be the infraspinatus. So these two muscles are very, very important for us. And on the anterior side, we have the subscapularis muscle. Okay, so these three muscles are very important to us. Now, how do you look at in the coronal image? So this is a coronal image. This one is a sagittal image. Okay, so only one muscle is important for you in the coronal image. Okay, or just one muscle and that is this muscle. Can someone tell me what is this muscle? Yes, this is my, again, supraspinatus. Supraspinatus. And this is the most common muscle to be injured in rotator cuff. Okay, so identifying supraspinatus is important for us. Okay, supraspinatus is the most common muscle to be injured in rotator cuff injuries. Supraspinatus. Good, good, good. Chalo. Now quickly tell me, this is very easy, so I'll just label sign and diagnosis. Okay, sign and diagnosis. Meanwhile, I'll also tell you few important pointers which help us differentiate and confirm our diagnosis. Okay, so first two images I am giving the history of cyanosis. I'm giving the history of cyanosis. Okay, so it is easy for all of you to answer now. Okay, so this is boot-shaped heart. Okay, diagnosis is TOF. Okay, now tell me what is the second diagnosis. One I have told you, tell me the second diagnosis. You see that the heart is enlarged. The heart is enlarged and the patient has cyanosis. Patient has cyanosis. And you see that there is pulmonary plethora. The pulmonary vessels are very well visualized. So, sorry, pulmonary vessels are not visualized. It is appearing black. Pulmonary vessels are small. So, we have reduced blood supply, enlarged heart and cyanosis. So, this is a typical triad of box-shaped heart. Good. This is box-shaped heart. Epstein anomaly. है ना? So now tell me otherwise. Again, the history of cyanosis is given. Again, I have given history of cyanosis in all three. So the first image is a typical TGA, egg on string appearance. Second one is truncus arteriosus. Clover leaf heart is classically told, but has never been asked. I don't think clover leaf heart will be asked. Again, TAP we see asked multiple times. Figure of 8. Okay, snowman's heart. Tell me in the comment section which is the type of TAP we see which has the worst prognosis. वर्स्ट प्रोग्नोसिस किसका होता है? इंफ्राकार्डियक टैप वी सी. Infracardiac has the worst prognosis. Yes. So why have I told you all the cyanotic heart disease? Because I want you all to remember that in TOF and in Epstein anomaly, you have pulmonary oligemia. You have reduced pulmonary blood flow. So another pointer to confirm TOF is no cardiomegaly and black lung fields. Pulmonary oligemia, reduced lung fields. So TOF will have normal heart size plus reduced pulmonary blood flow, whereas Epstein anomaly will have cardiomegaly. TOF will never have cardiomegaly in your question. ठीक है, this is a very very important pointer. अगर cardiomegaly दिख रही है, so revise your thought process. Maybe what you are seeing as a boot shaped heart is not actually boot shaped. Okay, now tell me quickly this diagnosis. I've already labeled it. Actually this is a sign. Tell me the sign. This is scimitar sign. ठीक है, seen in partial anomalous pulmonary venous connection. Now let's move on to the next topic, next spotter for us. ठीक है, I'm talking about, I think all of you know what I'm talking about, hydatid cyst. So hydatid cyst of liver. Hydatid cyst of liver. ठीक है. So what is the name of the classification? It is WHO classification. ठीक है, tell me in WHO classification which is the active stage, which is the inactive stage. So CE1 and CE2 are active. CE3 is transition. Both CE3A and CE3B, they are transition phase. And 4 and 5 are inactive. ठीक है. सो ट्रीटमेंट किस स्टेज में करोगे आप? एक्टिव स्टेज या ट्रांजिशन स्टेज में एल्बेंडाजोल का ट्रीटमेंट होगा. Now radiological treatment that we do, which is in fact the treatment of choice for hydatid cyst of liver, is PAIR or PAIR. It stands for puncture, aspiration, instillation and reaspiration. So puncture of what? Puncture of the cyst. So which cyst can you puncture if it is a unilocular cyst? So CE1 is a unilocular cyst. So remember, PAIR is done in only CE1 hydatids. Potential question, very very important. PAIR is done for CE1 type of hydatid cysts, because in CE2 you will have multiple daughter cysts. You cannot put a catheter in each of the cysts. So it is done in a unilocular cyst. Now what do we do in PAIR? Through a needle, we puncture the hydatid cyst, aspirate out all the contents. Then we put in a scoliocidal agent. Most commonly used is a 95% absolute alcohol. And then we re-aspirate the absolute alcohol. So absolute alcohol is a scoliocidal agent. It kills the endocyst. That is why the hydatid gets killed. So PAIR is the treatment done in CE1 hydatid cyst only. Okay. So quickly tell me the name of the signs. So in CE1, what do we get? We get hydatid sand on ultrasound. In CE2, we get honeycomb appearance. In CE3A, what is this sign? Very classical sign of Hydatid. Water lily sign. Now CE4, the name of the sign is a cotton wool sign. Cotton wool appearance. And then finally in the CE5, we have a calcified Hydatid. So see this calcified wall, this is the calcified Hydatid. Chalo, next. So now we'll come to bone tumors. So bone tumors are very, very easy now. I don't think anybody has any problem in bone tumors. They're very easy to understand. So 15-year-old boy, tell me the diagnosis quickly. Okay, so the lesion is in my epiphysis and the apophysis. So epiphysis and apophysis में unilocular lytic lesion है. Lytic lesion, let's not call it unilocular. It's a lytic lesion in the epiphysis, apophysis. Child है 15-year-old. It is benign looking. Why? Because there is no cortical breach. There is no joint invasion. There is no abnormal periosteal reaction. So हमारे buzzwords क्या होंगे? Young epiphysis, lytic lesion, diagnosis is chondroblastoma. ठीक है. Now next question, chicken wire calcifications are seen in chondroblastoma. ठीक है, that's why I've written chicken wire. Chicken wire calcification. चलो next quickly, 35-year-old female, epiphyseal lesion reaching till the articular surface, no periosteal reaction, no cortical breach. So benign looking lytic lesion, epiphysis. So benign lytic epiphysis, adult, diagnosis is GCT, giant cell tumor. ठीक है. Now फटाफट next, diaphyseal metadiaphysis, और लोकेशन क्या है इसकी? metadiaphysis of the femur, टिपिकली शेफर्ड क्रूक डिफॉर्मिटी करा रहा है. ग्राउंड ग्लास मैट्रिक्स है, ग्राउंड ग्लास मैट्रिक्स. सो बज़वर्ड्स आर ग्राउंड ग्लास मैट्रिक्स, metadiaphysis, benign looking, okay, and shepherd's crook deformity. Diagnosis is my fibrous dysplasia. ठीक है. Now two syndromes already you guys know, so I won't tell. This is McCune-Albright, right, and Maza-Brod syndrome. ठीक है. McCune-Albright has a triad. Okay, there is fibrous dysplasia, precocious puberty, and cafe-au-lait spots. ठीक है. This is McCune-Albright syndrome. Polyostotic FDs are seen. चलो, diagnosis. Benign looking, there is no cortical breach, there is no soft tissue. So benign looking, typical location tibia and involving diaphysis. ठीक है. So tibia अगर दे रखा है, diaphysis का दे रखा है lesion, benign appearing है. Why? Because no cortical breach. तो आपका आंसर क्या होगा? No. Adamantinoma. This is adamantinoma. Why? Because this is lytic. Lytic है. अब लोग बोल रहे हैं कि osteoid osteoma नहीं, osteoid osteoma sclerotic tumor है. Osteoid osteoma is sclerotic. There is a lot of sclerosis that you see, right? Ewings में क्या होगा? Onion skin periosteal reaction होगा Ewings में. यहाँ पर कोई periosteal reaction है? No. This is a solid periosteal reaction. There is no cortical breach also. So this is definitely not Ewing sarcoma. ठीक है. Diaphysis क्यों है? क्योंकि ये हमारे एपी है, ये मेटा है. This whole is my diaphysis. Any doubt? No. This is adamantinoma. Now quickly next. Okay, I have not even given the image. ठीक है, what is this appearance, what is this diagnosis? So benign appearing mass because there is no cortical breach, so this is benign. This is metaphysis because epiphysis I can see separately, so metaphysis, benign. Lytic, child क्यों? Because the growth plate is not fused, so this is child. And there is soap bubble. Answer is aneurysmal bone cyst. ठीक है, aneurysmal bone cyst multilocular है ना, एक loculi ये है, ये है, ये है, ये है, so aneurysmal bone cyst. Simple bone cyst will have only one loculi. I'll show you the image of a simple bone cyst also. So look at this SBC, ठीक है, unilocular cyst with a fallen fragment sign, ठीक है, typical location in the metaphysis, so metaphysis. Unilocular characteristic location that is asked in the exam is upper end of humerus. And signs we have already covered. This is fallen fragment sign. And tell me another sign. Can someone tell me another sign seen in simple bone cyst? This is simple bone cyst. Another sign that we see is a trap door. Good. Hinged door or a trap door sign. Chalo, next. Tell me what is the diagnosis? What diagnosis have you made? So first of all, chondroid matrix. Okay. Chondroid matrix, cloud-like ring and arc type of matrix. And I have given you also image of a hand. So tumors of hands and feet, small bones of hands and feet. पैथोग्नोमोनिक है, अगर एग्जाम में हैंड का एक्सरे दे दिया है और ट्यूमर दिख रहा है उसमें, ट्यूमर कैसे चलता है पता? कि देयर इज अ लिटिक लीजन, देयर इज अ लिटिक लीजन लाइक दिस and it is causing bony expansion. There is mass effect, there is bony expansion. So this is not an infection, this is a tumor. This is not infection, this is tumor. And benign versus malignant, how will I tell? There is no cortical breach, cortex is intact, so this is a benign lesion. So number one pointer is benign. Small bones of hands and feet, ठीक है, एंड कॉन्ड्रॉइड मैट्रिक्स. ठीक है, सब लोगों ने आंसर दे ही दिया है. गुड. आंसर हेयर इज एनकॉन्ड्रोमा. And I've kept this image of femur for enchondroma also because I want to tell you that enchondroma not just happens in small bones of hands and feet, it is in fact very common in long bones as well. And in the long bones enchondroma, लॉन्ग बोन्स में एनकॉन्ड्रोमा मेटाफाइसिस में मिलेगा एंड इट विल शो कॉन्ड्रॉइड मैट्रिक्स. ठीक है, दिस इज हाउ माय कॉन्ड्रॉइड मैट्रिक्स लुक्स लाइक. क्लाउड लाइक बोलते हैं इसको, क्लाउड लाइक या फिर रिंग एंड आर्क टाइप. So enchondroma. So two syndromes associated with enchondroma you already know, Olliers and Maffucci's. Olliers has multiple enchondromas. Maffucci's has enchondromas plus soft tissue hemangiomas. Now tell me what is amongst Olliers and Maffucci's. So solitary enchondroma versus multiple enchondroma, which has higher risk of malignancy, or both is the same, both have the same risk of malignancy? Yes, multiple enchondromas have higher risk of malignancy. So tell me the diagnosis here. I have seen this is an X-ray of the knee of a child. Why? Because child, the growth plate is open, and I can see onion skin periosteal reaction, multilamellated periosteal reaction. If history is given, typically a history of fever, erythema, is given mimicking a osteomyelitis, but this onion skin periosteal reaction child diaphysis location. This is pathognomonic of Ewing's sarcoma. Small blue round cell tumor. Good. This comes in the family of small blue. What other tumors come in the family of small blue round cell tumor? Can someone tell me in the comments, in the chat box? Small blue round cell tumors. SBRCT. So एक आता है इसमें Ewing's, न्यूरोब्लास्टोमा, rhabdomyosarcoma and retinoblastoma. ठीक है, RMS is rhabdomyosarcoma. RMS very very important tumor. Rhabdomyosarcoma. Good. Chalo, next diagnosis. So this is a young adult, 25-year-old male, comes to you with severe pain in the legs, which worsens at nights and relieves on taking NSAIDs. So typical history, typical imaging findings, typical easy diagnosis. So not wasting much time, everybody knows this, osteoid osteoma. What are the buzz pointers for osteoid osteoma? So first of all, location is diaphysis. ठीक है, there is nidus plus surrounding sclerosis. Okay, this is the nidus and this is the sclerosis. ठीक है, clinical features typically very intense pain relieved by aspirin. And treatment, tell me guys, treatment is simple radiofrequency ablation. Chalo, next diagnosis. So adult with no incidentally detected. Okay, adult with left knee pain. Adult with the left knee pain. Simple, I'm telling you. Okay, you see an exostosis. So diagnosis is very clear to everybody. Osteochondroma. Okay, you have a lesion coming out from the growth plate with a cortical continuity. Cortical and medullary continuity. है ना, cortical medullary continuity. Second important location is metaphysis, and the buzzword here is grows away from joint. ठीक है, these are the three buzzwords regarding osteochondroma. Now it's important because it has a malignant potential. So malignant potential के लिए investigation of choice everybody knows, it's an MRI. What are the criteria for malignant transformation? Tell me three criterias. ठीक है, cap more than 1.5 centimeter, persistent pain. Third is growth after puberty. ठीक है, 3 criteria for malignant transformation. And cartilaginous cap के लिए investigation of choice is MRI. ठीक है, 1.5 to 2 मान लो, ठीक है, कहीं कहीं 1.5 दे रखा है, कहीं कहीं 2 दे रखा है, बट दिस इज व्हाट इज 2 to 1.5 centimeter is fine. Now typical, not wasting time on this, diagnosis is osteosarcoma, everybody knows. ठीक है, मेटाफाइसिस, sunburst, periosteal reaction, okay, and sclerotic looking tumor. So tell me, just remember 25% of osteosarcomas are lytic, and most of these are telangiectatic. Telangiectatic variety of osteosarcoma. Chalo. Easy peasy. Now again a malignant looking tumor involving the pelvis. And what do you see here? You see these multiple big ring and arc type of calcifications. So this is typical of chondrosarcoma. Chondrosarcoma. So let me tell you something about pelvic tumors. Pelvic tumors. That is pelvic bone. I'm talking about pelvic bone tumors. Pelvic bone tumors. Okay, so if pelvic bone tumors, malignant pelvic bone tumors is asked to you, so remember, in a child, most common malignant pelvic tumor, okay, or for that matter any flat bone tumor, I'm in general talking about flat bone tumors arising from flat bones like pelvis, like scapula, these are flat bones, ribs, these are flat bones. So children may most common malignant cause is Ewing's, whereas in adults it is chondroblastoma. Okay, remember, it is not osteosarcoma or something else, it is Ewing's and chondroblastoma, especially flat bone ke tumors. Now continuing with musculoskeletal imaging, ठीक है, name the sign and diagnosis. ठीक है, easy. Sign is a dagger sign. Diagnosis is ankylosing spondylitis, right? Other signs that we see here, ठीक है, tram track appearance, Anuj, I have, okay, adults may I have chondrosarcoma. Okay, I'm sorry. Thank you, Anuj. Thank you. For adults, it is chondrosarcoma. Sorry. Thank you for correcting me. So this is tram track appearance. Other sign is tram track appearance. The sign given here is a dagger sign. Okay. So first hallmark of ankylosing spondylitis is sacroiliitis. Okay. And investigation of choice for sacroiliitis, this is MRI. Okay, yes, it happens in young males. So males like you and I, young males are affected in ankylosing spondylitis. Now again, I've given you a hand X-ray, and this X-ray should immediately point to you about some pathology. So we can see that there are erosions and narrowed joint space in the wrist, and also the proximal interphalangeal joints are affected. The distal interphalangeal joints are normal. So what am I talking about? If I additionally give you the history that the patient has swollen joints, swollen fingers, swollen wrist, erythema, pain, etc., okay, what will you point towards? This is RA. Yes, this is RA, rheumatoid arthritis. Okay, good. Now regarding RA versus osteoarthritis versus psoriatic arthritis, what are the pointers? So RA typically affects PIP, OA typically affects DIP, and PSA, psoriatic arthritis, also affects distal interphalangeal joints. Okay, but in addition to DIP involvement in psoriatic arthritis, you have deformities also, like penicillin cup, telescoping of bones. These are also seen in psoriatic arthritis. And this is an example of my penicillin cup deformity because of DIP and PIP both involvement. But DIP is typically involved in psoriatic arthritis. Chalo, next diagnosis, sudden onset severe pain in the foot after a episode of binge drinking. So sometimes you may be given a history of binge drinking, sometimes it may not be given. Okay, but we know that acute monoarthritis, if it is asking us, it is nothing but gout. ठीक है, so gout में what will be the cardinal features? So these big erosions, these are known as rat bite erosions. So question hallmark of gout arthritis is number one, rat bite erosions and relative preservation of joint space. So you see that the joint space here is relatively preserved, है ना? Joint space is preserved. Second important point is preservation of joint space. Correct. And third important point is presence of soft tissue tophi, soft tissue deposition of monosodium urate crystals that we call as tophi. Okay, and which is this investigation that I am showing you? This is dual energy CT, which shows us these green areas of deposition. What are these green areas? These are nothing but monosodium urate crystals. Chalo, next. So give me this diagnosis. A diabetic patient comes to the emergency with occasional dislocation of the foot. Mild occasional pain is also noted, and you get an X-ray of the foot. It is so damaged, it is so destroyed. So this is typically an example of neuropathic joint or Charcot's joint. Right? Charcot's joint or neuropathic joint. What are the 6 Ds that we typically read here? So distension of joint, debris deposition, disorganization, increased density, destruction of joint, and one more, I think it is disintegration, but you get the gist. Basically what happens here is that clinically the patient might not have a lot of symptoms, but there is radiologically a lot of destruction. Why? Because there is no painful feedback that is going to the patient. So there is clinico-radiological mismatch that we see in Charcot's joint. Now finally, two important metabolic bone disease. So we are just finishing with our musculoskeletal radiology, and then we'll finish today's class quickly. ठीक है, now tell me this, easy for all of you. ठीक है, rickets की बात कर रहे हैं हम. Clinic radiologically what do we see? We see cupping, ठीक है, fraying and splaying of metaphysis. ठीक है, typically if you're given a hand x-ray, the examiner is most likely asking rickets. If he is giving a knee x-ray, most likely asking about scurvy. So scurvy के important signs, tell me guys. So this is Wimberger's ring sign. Then we have white line of Frankel. Then Tremor field radiolucent zone. And then a Pelkin spur. ठीक है, now scurvy में शायद आपको ये ना दिया जाए. You might be given a skull radiograph or a skull CT scan, and there you will see subperiosteal hemorrhages. So what are other radiological signs of scurvy? So you can get other radio signs. So you can get subperiosteal hemorrhages, and you can get thinning of cortex. Pencil thin cortex we call them. See how the cortex is so thinned out. Okay, this is what is known as pencil thin cortex. Yes, tender ribs can also be seen. Scorbutic rosary बोलते हैं उसको. ठीक है, tender ribs can also be seen here. So now tell me, come on quickly, what is the diagnosis here? Elderly postmenopausal female comes to you with low backache. ठीक है, diagnosis is my here osteoporosis. I am seeing fish mouth vertebra. Name of the sign is fish mouth vertebra. Investigation of choice is DEXA scan. Now tell me, DEXA scan में where do we measure bone mineral density? Which bones do we use to measure bone mineral density in DEXA scan? So number 1 is neck of femur, number 2 is wrist, and number 3 is lumbar vertebra. ठीक है, DEXA में you measure bone mineral density. ठीक है, so this was about osteoporosis. Now I know you know the definition of osteoporosis. The definition of osteoporosis is T score less than minus 2.5. Between -1 to -2.5 is osteopenia. Now some spotters related to spine. ठीक है, the first one is ivory vertebra. Which conditions do we see ivory vertebra? Paget's, lymphoma, metastasis. What kind of metastasis? Sclerotic mets. Which tumors have sclerotic mets? Prostate, and breast. Now, if asked most common type of metastasis in breast, so most common type of bone mets in breast CA is mixed lytic and sclerotic. Now, what is the second image? This is my picture frame vertebra. Where do I see picture frame vertebra? Again, seen in Paget's. Now, bone within bone appearance. This is seen in osteopetrosis. No, renal osteodystrophy is different. Renal osteodystrophy will have rugger jersey spine. Now, what is rugger jersey spine? That alternate bands of sclerosis and lysis. So, that is rugger jersey spine. This is not rugger jersey spine. In this spine, only one vertebra is affected, which is picture frame vertebra. That is outer sclerosis of the vertebral body, picture frame vertebra seen in Paget's disease. Now let's come to a few questions. A child with acute ALL undergoes prophylactic irradiation prior to autologous hematopoietic stem cell transplant. Which of the following will be least affected? So he is going irradiation. Okay, so patient is question is basically asking which is the most radio resistant tissue or cells. Okay, so let's come to this table. Radio sensitive and radio resistant cell, tissue, organ, blood cell and cell cycle. So the most radio sensitive cell cycle is G2M, followed by M phase. Resistant is my S phase. Similarly, most radiosensitive tissue, if asked, is bone marrow. Radio-resistant is neuron. Organ, if it's asked most sensitive, they are gonads. Organ most resistant is vagina. And if asked about the blood cell, sensitive are WBCs and resistant are platelets. Right? So if in this question, which will be the least affected, that is, which will be the most radio resistant, answer will be neurons. Neurons are very radio resistant. That is why, you give prophylactic irradiation to the brain and nothing happens because neurons are radio resistant. Now, since we are talking about radiotherapy, I want to cover fractionated radiotherapy because this has been asked in previous FMGE and not a lot of colleges cover this fractionated radiotherapy. So whenever we are planning any radiotherapy session for a patient, so let's say we plan a total dose of around 60 grays, 66 to 70 grays, we plan total radiation. Now we cannot give it in one sitting because then the side effects in the form of skin burns will be a lot. And second, importantly, because we have just read that S phase is the radio resistant phase. So whichever cells of the tumor are in the S phase, they will also not get killed because it is radio resistant phase. Only the cells which are in G2M and M phases, only they will be killed by radiation therapy. So that is why we divide the whole dose into multiple small doses, and also we give 2 days a week as holiday from irradiation. So जो छुट्टी आपको MBBS में या रेसिडेंसी में भी नहीं मिलेगी, वो irradiation के टाइम पे पेशेंट्स को मिलती है, weekends पे, Saturday Sunday. Why? Because we want the cells in the S phase to come into the G2M or M phase. Now S phase specifically कौन सा है? Late S is the most radio resistant. So what have we done in fractionated therapy? We have divided the total dose into multiple small doses and we give doses 5 days in a week. So Saturday and Sunday are holiday. Okay, so single high dose will destroy both normal abnormal cell. If we give fractionation, the normal cells will get time to repair because their DNA repair mechanisms are active. In cancer cells, the DNA repair mechanisms become defective, correct? Now, normal fractionation may, how do we divide it? So normally, how do we divide? We give per day dose per day, that is one fraction per day of 1.8 to 2.2 grays. कितना ही देंगे एक दिन में? This is dose per fraction, and we give one fraction per day. So patient आया मंडे को, उसको 1.8 to 2.2 ग्रे मिला. ट्यूसडे को भी सेम, वेडनेसडे थर्सडे फ्राइडे सेम 1.8 to 2.2 ग्रे per day. So one fraction per day, 5 days a week. This is the normal fractionation. Now there are few terms known as conventional fractionation, hyperfractionation, accelerated fractionation, and hypofractionation. Hypofractionation. So first let's understand hypofractionation. Now इसमें dose तो हमें total उतनी देनी है. Total dose is 66 grays only. ठीक है, बट हमने क्या किया कि पर डे जो डोज दे रहे थे हम, उसको हमने 2.2 से ज्यादा कर दिया. ठीक है, तो हमारे टोटल फ्रैक्शंस कम हो गए. सो हमारे टोटल फ्रैक्शंस कम हो गए. सो विद द हेल्प ऑफ हाइपोफ्रैक्शनेशन, इन हाइपोफ्रैक्शनेशन व्हाट हैपेंस, per fraction dose is more than 2.2 gray. So let me write it here only. Normal fractionation is 1.8 to 2.2. So if it is less than 1.8 gray per day, this is known as hyperfractionation. And if it is more than 2.2 gray per day, it is known as hypofractionation. Right? So if my per day dose is more than 2.2, I'll call it hypofractionation. And by the logic of it, if I'm giving more dose in one day, then the total number of days will also reduce. So the advantage of hypofractionation is that the entire dose gets completed in 6 weeks and only one fraction per day. So shorter duration and higher dose per fraction. Now in comparison, if we increase the number of fractions per day, so we are giving both morning plus evening. So one morning, one evening. Okay, so 5 days a week again. So since we are giving morning and evening, per dose per fraction dose we can reduce. So here the fraction dose is less than 1.8 gray per fraction. So here it is written 1.15. You remember less than 1.8 gray per fractions. But you are giving fractions morning, evening, morning, evening, morning, evening. Now here also the total number of dose, total number of duration is still high. Okay, so this is the most important two types of hyperfractionation, hypofractionation and hyperfractionation. Now just take a screenshot of this. There is nothing to understand in this table. Common isotopes and their half-life can be asked sometimes in the exam. It will be a one-liner only. So if you get it right, you get it right. If you don't know, you don't know. That's it. Okay, so amongst these, which are the more important? So technetium 99M, very important. 18F, very, very important. So 18F is used in PET scan. Okay, positron emission tomography, not single photon wala SPECT hai. This is positron emission tomography, hai na? Technetium 99M used in gamma camera. Okay, cobalt 60 very commonly used agent for external beam radiation therapy. Remember 5.2 years. And then common iodine isotopes you can also remember. So how I remembered 131 and 125. So 12 into 5 was 60. So I remember 60 days was 125 ka half life. Similarly 3 ko I can convert it into 8. So 8 days for iodine 131. So that is how I remembered. You can make your own mnemonic for this as well. Now head trauma, very easy. I think a lot of you already know this. So EDH versus FTH, very commonly asked. Okay, there was a time when it was asked every time in ionized CT, but now the trend has finally come down for good, I would say. So EDH will be what? EDH will not cross sutures. It will mostly be biconvex, but let's keep it not very important. It will not cross suture EDH. That is the most important point. Okay. Can it cross midline? Yes, it can cross midline. So can I have an EDH like this? Yes, I can have an EDH like this. Yes, frontal lobe mein I can have an EDH like this because it can cross midline. Okay, whereas FDH, if you talk about it, it doesn't. It can cross sutures, but it can not cross midline. है ना? एंड शेप, आप शेप बोलने को बोल दो, कॉनकेवो कॉन्वेक्स शेप, पर जब एक्चुअली में पिक्चर आती है ना एग्जाम में, तब कॉन्वेक्स और कॉनकेव से क्वेश्चन सॉल्व नहीं होते. तब क्वेश्चन सॉल्व होगा कि सूचर क्रॉस कर रहा है कि नहीं, मिड लाइन क्रॉस कर रहा है कि नहीं. ठीक है, ये इसका निचोड़ है. दिस इज द एसेंस ऑफ दिस कंसेप्ट, ईडीएच वर्सेस एफडीएच. चलो एसएच, again where will you see the bleed? You will see the bleed in the basal cistern and the sulcal spaces. So mota if we talk about investigation of choice in head trauma, it is NCCT head. So if it's asked investigation of choice for SAH, investigation of choice to pick up EDH, FDH, it will always be NCCT head. But if you're asked non-traumatic patient, SAH on NCCT. Now investigation of choice to see cause of SAH. Now here the answer will be CT angio, CT angiography. Okay? And in a similar situation, if you're asked about gold standard, then the answer will be DSA. Then the answer will be DSA. So tell me, what is the most common cause of SH? It is trauma. If I'm asking what is the most common cause of non-traumatic SH, it is berry aneurysm. Chalo, next question. Okay, so this was a question that was asked in May 2018 INICT. So this is the image that was given in May INICT. And the history was given that the child had a fall 2 years ago, and the mother has now noticed that since the last 7 to 8 months, there has been a swelling in the scalp which is continuously increasing in size. So this is a typical history that is provided, and this is the skull X-ray that you are given with. What is the diagnosis? Diagnosis in such cases is a growing skull fracture, also known as a leptomeningeal cyst. Okay, yes, you're right. So what happens basically in an old trauma case, there is a dural tear. So the dural tears off, then the CSF comes through this dural tear and gets deposited, gets accumulated in the scalp. And slowly, as the child grows, the CSF keeps on leaking, and this fracture line widens up. That is why leptomeningeal cyst or a growing skull fracture. This is the diagnosis. Now, similarly, diffuse axonal injury, very important head trauma injury. So which, first of all, tell me the investigation of choice for diffuse axonal injury. It is my MRI. And in an MRI, which is the sequence of choice? Sequence of choice is SWI, or sometimes you can be given GRE, or sometimes you can also be given SWAN or T2 star. All these are same. Now, how will you identify? Keyword will be NCCT is normal, but GCS is poor. So patient will be a road traffic accident patient who comes to the casualty with the GCS of 8. NCCT head is normal. What are you suspecting? You're suspecting diffuse axonal injury. For that, the investigation of choice is an MRI. Now, tension pneumocephalus asked in this sign ICT. So, name the sign. ठीक है, Mount Fuji sign. Mount Fuji sign, direct straightforward question which was asked. So what do we see? That the air in the cranial cavity is under pressure. That is why it is causing tenting of dura. This is tenting of dura due to air inside the cranial cavity which is under tension. So tension pneumocephalus. Mount Fuji sign. Now another cause of a head trauma, you will see potential question in my opinion. A patient with a head trauma develops chemosis of one eye and pulsatile proptosis. Question buzzword: pulsatile proptosis and ipsilateral chemosis. Red eye, pulsatile proptosis point towards carotico-cavernous fistula. There is a fistulous communication between the cavernous sinus and the internal carotid artery. That is why through the ophthalmic artery you can see pulsatile proptosis. So how do you identify? On a CT scan, you see prominent superior ophthalmic vein. ठीक है? So investigation of choice for a carotico-cavernous fistula is CT angiography. Gold standard remains DSA because it is both diagnostic and therapeutic. Now someone is saying in the comment section it is cavernous sinus thrombosis. No, I am showing you a prominent superior ophthalmic vein. In a cavernous sinus thrombosis, this bright area will not be visualized. This will be dark. Why? Because there is thrombus. This is not cavernous sinus thrombosis. This is, and also cavernous sinus thrombosis will not cause pulsatile proptosis. Pulsatile proptosis is a very pathognomonic sign of carotico-cavernous fistula. Now, cerebral vein thrombosis. Cerebral vein thrombosis. What are the signs that we see? Signs are delta sign and empty delta sign. So delta sign is seen on non-contrast CT, empty delta sign on a contrast enhanced CT. So what is a delta sign? Basically acute thrombus. Acute thrombus is bright. That is why you see acute bleed in EDH, in SDH as bright, as hyperdense. So acute thrombus is bright on a non-contrast CT. So that is why you'll get acute triangular shade opacity in the superior sagittal sinus, which is in fact the most common site of venous thrombosis in the brain. You'll see a triangular opacity, which is nothing but my thrombosed superior sagittal sinus. And if you give contrast, then the surrounding thin rim of the superior sagittal sinus may enhance, but the center thrombus will not enhance. This is my empty delta sign. This is empty delta sign. Now we are just about to finish. A 2-month-old infant brought to the OPD with parietal swelling since birth. X-ray is given below. What is the probable diagnosis? So here I am seeing that this is the swelling which is lifting up of the periosteum. There is lifting of periosteum. So what is this swelling which is present till birth? This is cephalhematoma. This is cephalhematoma. And also the another pointer is a 2-month-old infant. 2 months तक caput नहीं बनता है. So this is cephalhematoma. This is a typical appearance. Cephalhematoma will cause periosteum to be risen, will cause lifting up of the periosteum. Whereas Galeal hematoma, caput succedaneum, this will not obstruct any of the periosteal layers. What is this image showing? This is occipital encephalocele, and it is associated with type 3 Chiari malformation. Yes, there is a type 3 also, which is associated with occipital encephalocele. Chalo, last question for the day. A patient presented with abdominal pain and sterile pyuria. An X-ray showed the following features. What is the, sorry, the X-ray is not shown. Okay, we'll skip this question. Okay, so let's just first of all recapitulate our whole radiology, and then let's just understand what is the first investigation. When the examiner asks us what is investigation of choice, what is the gold standard, what do we mean by these terms? So first investigation is the investigation which is the screening investigation. It is same as screening investigation. Okay, so screening investigation, for example, most commonly this is asked in acute abdomen. Acute abdomen में screening investigation is always an ultrasound. Okay, now investigation of choice is that investigation which is most sensitive, and gold standard is one which is most specific. That is why you can also do therapeutic interventions. Okay, so I am talking about now investigation of choice. So whenever एयर कंटेनिंग पैथोलॉजीज के बारे में बात हो रही है, फॉर एग्जांपल न्यूमोथोरैक्स, न्यूमोपेरिटोनियम, न्यूमोमीडियास्टाइनम, न्यूमोकेफिलस, न्यूमो एम्फाइसेमेटस पाइलोनेफ्राइटिस, एम्फाइसेमेटस polycystitis, air containing pathologies, what will be my investigation of choice? It will be NCCT. ठीक है, now whenever fluid containing structures are to be seen, ठीक है, gall bladder is a fluid containing structure, free fluid in the abdomen, fluid containing, for example cyst है, gall bladder है, for these the investigation of choice will be an ultrasound. Now calcification, for such investigation of choice will be NCCT. Now these can also include parenchymal calcification and calcium containing stones. So gallbladder stones which are not calcium rich, they do not appear bright on NCCT. Hence for gallbladder calculi, the investigation of choice is ultrasound. Gallbladder calculi have cholesterol and pigments. They do not have calcium. That is why for them investigation of choice is an ultrasound. For renal stones which contain calcium, most commonly the investigation is NCCT. Okay. Now for bleed, whenever acute bleed is to be asked, again the answer will be NCCT. So NCCT will be for air, bleed and calcifications. Now soft tissue, the best investigation is MRI. Investigation of choice is MRI. Now bone cortex, C for CT. C for CT scan. Bone cortex investigation is CT. Bone marrow, M for MRI. Okay. Now lines, tubes, medical devices, we want to see their position. What will we order? We'll order in plain X-ray. This will be the investigation of choice. For vascular pathologies, now vascular pathologies is a very difficult ball game. So for vascular pathologies, remember the first investigation is usually a Doppler. The investigation of choice is a CT angio. It has two exceptions, the investigation of choice. For example, in renal artery stenosis and in carotid artery stenosis. In these, the investigation of choice is MR angio. Okay, and gold standard is DSA. Now, when we talk about foreign body, especially metallic foreign body, because that is the most common foreign body which is there, metallic foreign body. For this, the investigation of choice is NCCT. Now, finally, we'll discuss about types of biopsy now. So, suppose this is my okay, this was the axilla. There were some lymph nodes here. Okay, so one of the what is excision biopsy, that I have taken out whole of the lymph node. So that will be the excision biopsy. Okay, so for example, there was a breast lump, small breast lump, likely a fibroadenoma. The surgeon has taken out the entire lump. That is an excision biopsy. Incision biopsy is that you have taken a small part of that lesion. Now, this incision biopsy is the term which is commonly given to open incision biopsies. But if you are taking a biopsy of only a part of the lesion without putting in a cut, but just with the help of an ultrasound guidance, with the help of these needles, then we call them as core needle biopsy, true cut biopsy, core biopsy, whatever you want to call them. But these are also a type of incision biopsy. I've only taken a small part of the whole lesion, not the entire lesion. So true cut is a type of gun. This is a true cut biopsy gun, which has a shelf within it for putting up a tissue. Okay, so it has, whenever we fire this gun, then the blade runs over this shelf and cuts the tissue. So a part of the tissue sits in between this tray. And this is what is my true cut biopsy. So true cut is a type of gun, but it is a type of incision biopsy. Now, what is FNAC? FNAC stands for fine needle aspiration cytology. Okay, so with the help of very fine needle, we take few cells out of the tissue. So in which cases will we do a biopsy? In which cases will we do an FNAC? So remember, in vascular lesions or in vascular organs, we always do FNAC. Biopsy is contraindicated. So for example, which vascular lesions? Like thyroid. Thyroid is a vascular organ. We never do biopsy. We do FNAC of thyroid lesions. Correct. Now, in which situations? So what is the advantage of doing a biopsy over the FNAC? Because biopsy will get a bigger tissue. ठीक है, so biopsy के साथ advantage है कि we get bigger tissue. So biopsy is preferred whenever we want molecular analysis, okay, or gene analysis, ठीक है, or we want to run immunohistochemistry, then we would prefer biopsy. So remember, in suspected lymphoma, in breast cancer, in lung cancer, we prefer and always do a biopsy. Prefer to always do a biopsy. So lymphoma may never mark FNAC as the option, mark biopsy. Similarly, breast cancer, breast lump, never an FNAC, always a biopsy. Right? Now, finally, I want to close this class today with some common radiation doses of common modalities. So just look at this table. I've taken this table from American College of Radiology. Okay, so chest X-ray is 0.1 millisievert, CT abdomen 8, CT chest 6, IVP 3. IVP is very important. Okay, barium enema is important, and digital mammography is important. So you can get a question that, does digital mammography has a higher radiation dose than chest X-ray? Yes, it has a higher radiation dose. Although We use lower KVP in digital mammo. We use a KVP of 30 to 40 kV, whereas chest X-ray around 70 to 80 kVp. But still the dose in digital mammography is more. Okay, remember this is a very, very important point. Okay, so with that, I'll close today's class. Thank you. If there are any queries, you can put them in the chat box. I'll be happy to answer them. So thank you, and I'll see you in the next.